Hello everyone. Today we are going to be covering chapter 24, that is fluids and electrolytes, homeostasis and imbalance. Body fluid flow in arteries, veins, and lymph nodes. Body fluids are secreted into specialized compartments, joints, cerebral ventricles, and intestinal lumen. Function of body fluid: surrounds and permeate the cell, lubricate and solvent for metabolic chemical reactions, transport oxygen, nutrients, chemical messengers, and waste products to their destination. Important in regulating body temperature. Let's keep going. Abnormalities in body fluid: volume, too much, excess, or too little, deficit. Concentration, altered. Electrolyte composition of body fluid: too much, hyper, or too little, hypo. Can cause clinical problem or death. Occur as a result of many different pathologic conditions. Body fluid pertain to water within the body and the particles dissolved in it. Two major body fluid compartments: extracellular and intracellular. The biggest one is the intracellular, with 2/3 of the body fluid. Location of extracellular fluid: intestinal compartment, between cells, vascular compartments, in blood vessels, dense connective tissue and bone, transcellular fluid, synovial, cerebrospinal fluid, GI fluid. Total body water. Total of the water in the fluid compartment, percentage of body weight that is water. It varies. It depends of the gender most of the time, because female have less body fluid than men. That means that women have less water because they have more fat. Fluid homeostasis: dynamic process results from interplay of four processes: fluid intake, fluid exertion, fluid distribution, and fluid excretion. Fluid intake is entering the fluid into the body by any route. When I say any route, that could be by oral, or if you are in the hospital, could be by IV. Other possible route of intake: intravenous intake tube in GI tract, subcutaneous tissue, rectal intake. And here we have question number 1. Okay, which primary stimulus for the sensation of thirst decline with aging? And the answer is D, increased serum osmolarity. You know that osmolarity is the amount of osmol per liter in your blood. Capillary force moves fluid from interstitial compartments into the capillaries. Capillaries homeostasis, osmotic pressure, inward pulling force of particles in vascular fluid. Interstitial fluids, hydrostatic pressure, outward push of interstitial fluid again outside of capillary wall. In other words, osmotic pressure is mainly by protein and keep fluid inside the blood vessel, and hydrostatic pressure is the pressure that is pushing fluid outside of the body of the blood vessel. Fluid distribution between interstitial and intracellular occur by osmosis. Remember that simple diffusion of water is osmosis. Cell membranes are permeable to water but not to electrolytes. In order the electrolyte to get inside or outside of the cell, they need proteins that are facilitated diffusion sometimes, or active transport. water across the cell membrane rapidly to equalize particles concentrations inside and outside the cell. Osmosis. Water goes to the higher osmolarity. That means the place that have more particles, more osmo, then the water go to that side. Water movement out of the cell occurs when particle concentration osmolarity in the interstitial fluid becomes higher than the particle concentration inside cells. Water movement into cell occurs when the osmolarity of the interstitial fluid becomes lower than the osmolarity of the intracellular fluid. We have urinary tract. That's the fluid excretion will be by the urinary tract, bowel, lung, and skin. Amount of fluids excreted in the urine is controlled primarily by hormones, especially ADH, aldosterone, natriuretic peptide, and other minor hormones. We have natriuretic peptide. Let me put it right here. You see, this natriuretic peptide that is produced in the atriums. That's why atrials. That's why it's natriuretic peptide. And brain natriuretic peptide, of course, is produced in the brain. ADAs are synthesized by cells in the hypothalamus, released from the posterior pituitary glands. Factors that increase release of ADH increase osmolarity, concentration of the extracellular fluid, decrease circulating fluid volumes, pain, nausea, psychological or physiologic stressor, cause reabsorption of water, which decreases urine volume and fluid excretion. Concentrated the urine, if ADH release is decreased, result in a large dilute urine volume, decreased osmolarity of extracellular fluids, ethanol intake. Later in this chapter, we are going to cover some diseases that are related to ADH. Aldosterone, synthesized and secreted by cell in the adrenal cortex, major stimulus for its release, angiotensin II, from the renin-angiotensin-aldosterone system, that's the RAS, and it's extremely important in patients with congestive heart failure, activated by decreased circulated blood volume, increased concentration of potassium ions in the plasma. Aldosterone causes renal tubule to reabsorb sodium and water, decrease fluid excretion, although by a different mechanism than ADH. When more aldosterone is secreted, urine volume is smaller. Decreased secretion of aldosterone causes a large urine volume. ADH versus aldosterone. ADH is tap water hormones, dilute body fluid. Aldosterone is the salt water hormones, expands extracellular fluid volume. Natriuretic peptide, A-type natriuretic peptide, normal secreted from cell in the heart when the atriums are stretched. Brain B-type natriuretic peptide is released from the ventricle cell when ventricle diastolic pressure increases abnormally, as in heart failure. That's why brain natriuretic peptide is the main thing that you measure in body when you want to diagnose heart failure. Okay? It's used to diagnose heart failure always. And these oppose the action of aldosterone, but not as strong as aldosterone. Natriuretic peptide promote fluid excretion into the urine by causing natriuresis, sodium excretion into the urine, When vascular volume increases, natriuretic peptide causes kidneys to excrete excessive fluid. When vascular volume is decreased, natriuretic peptide causes kidneys to secrete less fluid. Urine volume highly dependent on adequate volume blood pressure to perfuse the kidney. Glomerular filtration rate (GFR) may be a significant factor in altering fluid status. Example: emesis, tube in the GI tract or other body cavity, hemorrhage, drainage from fistula, wounds, or open skin, paracentesis. Emesis is vomiting. Paracentesis is when you take fluid from the ascites. It's fluid in the belly. Extracellular fluid volume can have too much, excessive, or too little deficits. Extracellular fluid involves a change in the amount or volume of extracellular fluid, also termed saline imbalance because they are disorders of isotonic salt water in the same concentration as the normal plasma concentration. Volume deficit caused by removal of sodium-containing fluid from the body, decrease in saline in the same concentration as normal extracellular fluid, and condition sometimes termed saline deficit. Uncomplicated extracellular fluid deficit, certain sodium concentration is normal, concentrations of extracellular fluid is normal, amount of extracellular fluid is abnormally decrease. Etiology: removal of the sodium concentrating fluid from the extracellular compartment, GI excretion, renal excretion, other losses. In the same instance, fluid is sequestered in the third space in the body outside the extracellular compartment, ascites. Ascites is when the fluid accumulates in the belly, especially in patients with liver disease, cirrhosis. Volume deficits, clinical manifestation, sudden weight loss, postural blood pressure decrease with concurrent increased heart rate, flagged neck vein or vein collapsing with inspiration when a patient is supine, lightheadedness, dizziness, syncope, oliguria or small amount of concentrated urine if kidneys are responding normally. Oliguria means that the urine output is decreased. We have oliguria and anuria. Clinical manifestation: decreased skin turgor, dryness of the oral mucosal membranes. That's especially what you measure in hospital. Always, you receive a patient, you always see. Don't say to the patient, please open the mouth. That's to measure the dryness of the mucosa. Hard stool, soft, succulent ice ball, longitudinal furrows in the tongues. In infant, fontanelle may be succulent. That's special signs of dehydration in infancy. Okay? Neck veins are not reliable associated in infants. Clinical manifestation: sudden weight loss is a sensitive measure of extracellular fluid deficit. 1 liter of saline weight equals weigh 1 kilograms. A person who lost 1 kilogram in 24 hours has excreted 1 liter of fluid or lost it through an abnormal route. It's not a reliable indicator for third spacing. Clinical manifestation: fluid volume depletion can be detected with shift of orthostatic blood pressure, may lead to a hypovolemic shock, which can be fatal if not treated effectively. Fluid replacement. Volume sex, opposite of extracellular volume deficit, amount of extracellular fluid is a normal increase. Vascular and interstitial area has too much fluid. Uncomplicated extracellular fluid excess, concentration of extracellular fluid is normal, excessive amount of fluid is present. Etiology caused by addition or retention of isotonic saline, sometimes termed saline excesses. Excessive secretion of hormones. Aldosterone cause kidney to retain saline, which may lead to extracellular fluid excesses. Compensatory mechanisms that can accompany chronic heart failure. That's why the RAS is extremely important in chronic heart failure, because in chronic heart failure you always activate the RAS. That's why those patients develop edema. Causes excessive intravenous infusion of sodium concentrating isotonic solution, renal retention of sodium and water. Clinical manifestations: manifestation of circulatory overload, bounding pulse, neck vein distension in upright position, crackle independent portion of lungs, dyspnea or tonia. Dyspnea is shortness of breath. Tonia is shortness of breath when you lay down. Sudden weight gain and sensitive measure of extracellular volume excessive. Edema is advanced frothy sputum of pulmonary edema in infant. Bulging fontanelle, a segment of neck vein is not affected in infants. Imbalance are disorder of concentrations and not the amount of extracellular fluid, also called water imbalance. Serum sodium concentration reflects osmolarity of blood, recognized by a normal serum sodium concentration. Hyponatremia. Hyponatremia means that the sodium is low, a serum sodium concentration below the lower level limit of normal. When present, the extracellular fluid contains relatively too much water for the amount of sodium ion present. Extracellular fluid is more dilute than normal. Etiology: factors that produce a relative excess of water in production to salt in the extracellular fluids. Cell swell, also called hypotonic syndrome, hypoosmolarity, water intoxication. Two primary causes: a gain of relatively more water than salt, prolonged or excessive release of ADH, water intake that exceeds normal limits, and loss of relatively more salt than water. Clinical manifestation: mild central nervous system dysfunction, malaise, anorexia, nausea, vomiting, headache, severe central nervous system dysfunction, confusion, lethargy, seizure, coma, fatal cerebral herniation. Hypernatremia. Hypernatremia: serum sodium concentration above upper limit of normal, extracellular fluid contains relatively too little water from the amount of sodium ions present, it is too concentrated. Cell shrill, also called water deficit, hypertonic syndrome, hyperosmolarity. Etiology: gain of more salt than water, loss of more water than salt. Clinical manifestation: we have mild, thirsty, oliguria, confusion, lethargy. Severe, we have seizure, coma, or death. Combination of two fluid disorder: extracellular volume deficits, hypernatremia, too small of volume of fluid in the extracellular compartment, and too concentrated body fluid. Etiology: vomiting, diarrhea, knowledge deficit about salt and fluid replacement. Clinical manifestations, we have postural blood pressure, decrease with concurrent increased heart rate, lightheadedness, dizziness or syncope and standing, flat neck pain when supine or neck pain that collapses during inspiration, sucking fontanelle in infancy, rapid tardy pulse, and sudden weight loss. Clinical dehydration continuation, we have decreased skin to gore, dryness of the oral mucosal membrane, hard stool, soft sucking ice ball, longitudinal furrows in the tongue, 30, increased serum sodium concentration, confusion, lethargy, coma, hypovolemic shock, oliguria. Edema is excess of fluid in the interstitial compartment, may be a manifestation of excess extracellular fluid volume, increased capillary hydrostatic pressure, too much volume from inflammation, increased interstitial fluid osmotic pressure. Inflammation causes protein to leak out from the vascular permeability. Excessive fluids in the interstitial compartment, blockage of lymphatic drainage, lymphedema, frequently localized, decreased capillary osmotic pressure, plasma protein decrease, excessive edema, extensive edema. And here we have another question. A patient have edema, what could have caused the edema? And the answer is A. Increase interstitial fluid osmotic pressure. Remember that if you change the osmotic or the oncotic pressure, that could cause edema. Electrolytes, ionized salt dissolved in water, most clinical importance: sodium, potassium, calcium, magnesium chloride, bicarbonate phosphate. Dynamic control: concentrate of an electrolyte in plasma is different from its concentration in the cell. For proper body function, electrolyte concentration must be normal in both the plasma and in the cell. Dynamic control: for process: electrolytes intake, electrolytes absorption, electrolyte distribution, and excretion. Processes work together to maintain dynamic control of electrolyte within normal limits. Dynamic control: if intake of a specific electrolyte increase, excretion of that electrolyte may increase to normalized plasma level. Similarity: if electrolyte intake decrease, electrolyte may be distributed into the plasma to maintain normal plasma level. Intake normal occur orally through food or drink. Other routes are oral medication, intravenous fluid, nutritional solutions. Other route: blood transfusions, administration of electrolyte, tube into the body cavity, nasogastric of GI feeding tube. Essential electrolyte absorption. Essentially, if electrolyte is to be useful metabolically, depend on other factors: concentrated gradients, binding proteins, content of the GI tract, pH of intestinal content, medication, surgical removal of portion of the GI tract. Electrolyte composition differs in various compartments. Concentration of potassium, magnesium, and phosphate ions are higher inside the cell. Extracellular fluid contains higher concentration of sodium, chloride, and bicarb. The main electrolytes is sodium and potassium. Okay? The biggest concentration of potassium inside the cell, the biggest concentration of sodium outside the cell. Influenced primarily by hormones: epinephrine, insulin, parathyroid hormones. Certain medication also influence electrolyte distribution. Occur through urine, feces, sweat, influenced by hormones, other factors, rate of renal fluid flow, medication, exit of electrolyte from the body through route are other than urine, feces, and sweat, may be controllable or may result from therapeutic procedures, alter electrolyte homeostasis. Examples are vomiting, nasogastric suction, paracentesis, hemodialysis, wound drainage, fistula drainage. Sepsis may be caused by increased intake, increased absorption, shift into extracellular fluid, decreased excretion. Deficits may be caused by decreased intake, decreased absorption, shift into electrolyte pools, increased excretion, loss through a normal route. Normal concentration, this is potassium 3.5 to 5. Most potassium, remember, always inside the cell. Hypokalemia, decreased potassium ion concentration in extracellular fluids. Etiology, decreased intake, usually in conditions that cause a decreased oral intake, shift into the cell, increased excretion, usually renal, but can be through feces, sweat, GI tract, emesis, diarrhea, diuresis. Clinical manifestation alters smooth skeletal cardiac muscle functions because of change in resting membrane potential, hyperpolarizations, abnormal abdominal symptoms. We have distension, diminished bowel sounds, paralytic ileus. That is special in elderly patients after surgery. This one, paralytic ileus. Skeletal muscle symptoms, bilateral muscle weakness, usually being in leg, respiratory paralysis. Also, we have altered smooth skeletal cardia. We already covered this one. Cardiac symptoms, we have ectopic beat, alteration in conditions. Dysrhythmia, remember arrhythmia, may be severe enough to cause sudden cardiac death. Polyuria is excessive of urine. Rates of serum potassium above 5 milliequivalent per liter, hyperkalemia. Depending in laboratory. Always, you as a nurse in the future, when you have a patient with hyperkalemia, the first step is to retake the sample. Okay, you have to draw blood again. Okay, and never tap. Okay, tap the little tap that you sometimes nurses do in the vein to see better the veins. Never tap the vein, because when you tap the veins, you break cells, and if you break cells, remember the highest concentration of potassium is inside the cell, and then that amount of potassium is released in the blood, and then you have a false positive. Increased potassium intake, rapid or excessive IV infusion, shift of potassium from cell to extracellular fluid, acidosis, crushing injury, decreased potassium excretion, oliguria, potassium-sparing diuretic, drug that produce aldosterone effect or other nephrotoxic. Clinical manifestation, muscle dysfunctions because of cause in resting membrane potential, hypopolarization, early mild intestinal cramping, diarrhea, late more severe muscle weakness, ascending beginning in the lower extremity, cardiac arrhythmia, and even cardiac arrest. Always you have to memorize that potassium, this K right here, potassium is always related with heart. That's why you say EKG, because K for potassium related with heart, sodium related with brain. Plasma calcium, present in three forms: bound to plasma proteins, bound to small organic ions, and unbound. Other free ionized calcium is physiologically active. Total serum calciums measure all of the calciums. Normal range in adult 9 to 11 or 4.5 to 5.5 milliequivalents. Unless a calcium value specifies ionized calcium, it is total calcium. The normal value is this one, 9 to 11. Most of the lab range from 8 to 10. Ionized calcium measure only the unbound ionized form. The normal range in adult 4 to 5. Clinical significant calcium imbalance are caused by alteration in the plasma concentration of unbound ionized calcium. Serum calcium concentration drop below the lower limit of normal, thus hypocalcemia. Fraction of unbound ionized calcium in the blood decreased by more calcium binding to plasma, protein, or other organic ions. The total serum calcium may be normal. Ionized hypocalcemia is present and may cause signs and symptoms. Etiology: decreased calcium intake or absorption, poor diet, lack of vitamin D, excessive phytate or oxalate, decreased physiologic availability of calcium, excessive phosphate hyperparathyroidism, increased calcium excretions, steatorrhea or pancreatitis. Clinical manifestation: decrease the threshold potential, causing hyperexcitability of neuromuscular cells, resulting in positive Trousseau sign and positive Chekhov sign. Positive Trousseau signs is when you put the cuff and you inflate the cuff in the patient. The patient have like spasm in the arm. Chekhov signs is when you touch the face and the patient have like fasciculations in the face. Paresthesia, muscle twitching and crampings. Hyperactive reflex. Clinical manifestation: decrease the threshold potential, causing hyperexcitability of neuron cells, resulting in carpal spasm, pedal spasm, tetany, laryngospasm, seizure, cardiac dysrhythmia. Action potential are regenerated more easily. Occur when the serum calcium concentration rises above the upper limit of normal, thus hypercalcemia. Indicate an elevation of the calcium concentration of the extracellular fluids. Etiology: increased calcium intake and or absorption. Milk algae syndrome is when you take a lot of vitamin D or calcium. Shift of calcium from bone to extracellular fluids. Hyperparathyroidism, immobilization, bone tumor. Decreased calcium excretions, thiazide diuretics. Clinical manifestations cause decreased neuromuscular excitability caused by elevation of the threshold potential of excitable cells, muscle weakness, diminished reflex, cardiac dysrhythmia. Clinical manifestation: other clinical manifestations, anorexia, nausea, emesis, fatigue, polyuria, constipation, headache, confusion, lethargy, personality change, renal calculi, pathologic fracture. Plasma magnesium normal 1.5 to 2.5. magnesium ions present in bound and unbound ionized form. Hypomagnesemia, serum magnesium concentration below the normal limit. Etiology, decreased magnesium intake or absorption. Chronic alcoholism, malnutrition, iliac resections. The most common cause is this one, normally, chronic alcoholism. Decreased physiological availability of magnesium, elevated plasma-free fatty acids, increased magnesium excretion, usually renal loss of magnesium by a normal route, emesis. Clinical manifestations: increased neuromuscular excitability from excessive amount of acetylcholine, insomnia, hyperactive reflexes, muscle cramps, muscle twitching, grimacing, positive Shaktov and positive Trousseau. These two, positive Shaktov and positive Trousseau, are more common in calcium, not in magnesium. Clinical manifestations: increased neuromuscular excitability from excessive amount of acetylcholine. We have nystagmus, dysphagia, ataxia, tetany, seizure. Nystagmus is a normal movement of the eyes. Dysphagia is problem swallowing. Ataxia is problem walking. Serum magnesium concentration above upper limit of normal. Hypermagnesemia. Etiology: increased magnesium intake or absorption. Laxative, antacids. There is one antacid that is based in magnesium, that's why it's one of the main cause. Decreased magnesium excretion, oliguria, renal failure, adrenal insufficiency. Clinical manifestations: depression of neuromuscular function related to decreased release of acetylcholine and neuromuscular junctions. Decreased depend on tendon reflex, lethargy, hypotension, flushing, diaphoresis. Clinical manifestation: also we have drowsiness, flaccid paralysis, respiratory depression, bradycardia, cardiac arrhythmia, cardiac arrest. Normal plasma phosphate, normal range in adult plasma 2.5 to 4.5. Symptomatic phosphate imbalance are less common than other electrolyte imbalance, however, they may be fatal if untreated. Hypophosphatemia, present when the phosphate is below 2.5. Clinical manifestation often not observed until severe, until concentration of phosphate is less than 1.5. Severe symptomatic hypophosphatemia. Etiology: decreased phosphate intake or absorption, chronic alcoholism, chronic diarrhea, malabsorption syndromes, antacid that bind phosphate. Phosphate is like a little bit related with calcium because vitamin D increase absorption of phosphate and calcium. Shift of phosphate from extracellular fluid to cell, refeeding after starvation, include anorexia nervosa, total parenteral nutrition, increased phosphate excretion, alcohol withdrawal, diuretic phase after extensive burn, emesis, hemodialysis. Clinical manifestation due in part to decreased ATP within the cell, also as a result of tissue hypoxia caused by decreased 2,3 biphosphoglycerates in the red blood cell, anorexia, malaise, hemolysis. Hemolysis is destruction of the red blood cell. Clinical manifestation also because of tissue hypoxia caused by decrease to 3 BPG in the red blood cell, paresthesia, diminution flex, muscle ache, weakness, respiratory failure. Also, we have confusion, stupor, seizure, coma, impaired cardiac function, hyperphosphatemia, increase of phosphate above 4.5, etiology, increased phosphate intake, oversuction, overzealous phosphate therapy, excessive use of phosphate-containing enemas or laxative, shift of phosphate from cell to extracellular fluid, tumor lysis syndromes, crushing injury, rhabdomyolysis, decreased phosphate excretion, chronic kidney disease, oliguria renal failure. We keep going. We have clinical manifestation, increased neuromuscular excitability, cause hypocalcemia signs and symptoms, excessive phosphate salts may deposit in soft tissue, depend on area where salts precipitate may cause aching and stiffness of joint, itching, conjunctivitis. We have question number 3. Which of the following electrolyte imbalance result in increased neuromuscular activity? And the question is D. Hyperphosphatemia. Electrolyte imbalance. You have a couple of questions of electrolyte imbalance in your midterm. Okay, so you have to study electrolyte imbalance. Infant variations. More extracellular fluid than extracellular fluid. More extracellular fluid than intracellular fluid, reversed by a few months of age, body weight is approximately 75% water, loss of fluid equivalent to 5 to 10% of body weight within first few days after birth, is part of a normal adjustment to extrauterine life. Neonates have a high metabolic rate, thus high turnover rate or water, increased insensibility water excretion because of proportionally large body surface area, proportionally large respiratory mucosa surface area, vasomotor immaturity, increased skin permeability. Glomerular filtration is lower than in adults. Kidneys have limited ability to concentrate urine, therefore unable to excrete large loads of water effectively, conserve fluid when needed. Communicate of thirst by carrying may not be understood by caregiver, result in dehydrations. Assessment of extracellular fluid imbalance should focus on tension of fontanelle, not on the neck vein filling. Laboratory normal range of electrolyte generally wider for infants than for older children or adults. Hypocalcemia more likely if resuscitating require at birth, infant is premature. More reliable physical signs of neuromuscular excitability, jitteriness, hypersensitive reflex, high-pitched crying, shocked off sign. Hypermagnesemia more likely if mother gives magnesium sulfate before birth, if power formula not properly diluted can result in hypernatremia. Magnesium sulfate is used when the patient with the pregnant woman have hypertension. preeclampsia. Yes, when the patient woman have preeclampsia, you give magnesium sulfate to avoid the pregnant woman to develop eclampsia. Eclampsia means hypertension with seizure. Age-related change results in decreased muscle mass, decreased fat in internal organ, less body water. Geriatric population is when you have an adult, elderly population, okay? Glomerular filtration rate is lower, kidney less able to concentrate urine, thus less able to conserve fluid when needed, contribute to nocturia, large volume of urine produced at night than in younger adults. Reduced thirst response may lead to decreased awareness of dehydrations. Older adults may have decreased tint, skin turgor even when appropriately hydrated. Older adults who receive tube feeding are at higher risk for hypernatremia. Older adults absorb more magnesium from antacids and cathartics, increase risk for hypermagnesemia. And we finish right here with chapter 24, and this is the first recording. Okay.